All right, picture this. It's a Tuesday morning in a universally chaotic referral hospital. Somewhere up on the third floor, you've got a nurse walking down two full corridors. Yet again, literally, just to find a simple pair of gloves. Downstairs, a patient who showed up at 7 in the morning has been waiting 4 hours just to be seen. And in the operating theater, a surgery is delayed, not because it's some wildly complex procedure, but because one basic instrument set is missing. This geography of waste, it feels incredibly common. We've all seen it. But here is the profound reality we're going to explore in today's explainer. This kind of chaos isn't actually an individual's fault. It is the system's perfectly designed flaw.
Okay, let's dive into this because this quote from Paul Batalden is quietly devastating when you really think about it. What he's saying here is that a maternal death in a rural facility or a 40% no-show rate at an outpatient clinic, well, those aren't just random misfortunes or bouts of bad luck. They are outputs. They are the predictable, statistically lawful consequences of exactly how that specific system is put together. Fixing healthcare isn't a problem of just telling people to try harder or putting up more motivational posters in the break room. It's fundamentally a problem of redesigning the system that produces the result.
And this brilliantly illustrates the core of the issue, which was originally identified by statistical pioneers like Schuhart and Deming. It's like a factory assembly line. Every single clinical process out there has two main enemies. On the left, we have common cause variation. These are your systemic expected fluctuations. On the right, special cause variation. These are your extraordinary, out-of-the-blue anomalies. Here's the catch. If you treat a common cause as an anomaly, like reprimanding a nurse for a delay that was actually caused by chronic understaffing, that is what they call dangerous tampering. But on the flip side, if you just shrug off a special cause as one of those things, we completely fail to learn and adapt. So here's our roadmap for this explainer. We're going to cover, number 1, the toolkit of variation. Number 2, the African reframe. Number 3, the limits of pure efficiency. And number 4, your Monday morning action plan. Let's jump right into Section 1, the Toolkit of Variation, where we'll look at Six Sigma, Lean, and Kaizen. While these three frameworks actually come from totally different industries, they all attempt to solve the exact same puzzle. How do you systematically shrink the gap between what a clinical process is technically capable of doing and what it actually does in real life? Let's begin with Six Sigma. This was born at Motorola and really made famous by General Electric. Its main engine is the DMAIC framework. That's define, measure, analyze, improve, and control. The primary goal here is laser-focused defect reduction. You measure your baseline, analyze it to find the vital few causes of errors, and then improve the process to hit a wildly ambitious target, just 3.4 defects per million opportunities. Because ultimately, you just cannot improve what you haven't first quantified. Let's see how this actually plays out in a real-world scenario. Take Mount Carmel Health System in Ohio. They had a median door-to-needle time for severe heart attack patients sitting at 53 minutes. They brought in Six Sigma. By totally redesigning how they handled ECG interpretations and pharmacy dispensing, they dropped that median time to an astonishing 23 minutes within just 6 months. I mean, they found the vital causes, they fixed them, and they literally saved lives in the process. Next up is Lean, which originally came from the Toyota production system. Its conceptual core is the relentless, absolutely uncompromising elimination of waste, or MUDA as they call it. Taiichi Ono identified these 8 specific wastes. When you bring this framework into a hospital, the whole building kind of transforms before your eyes into a landscape of visible waste. That nurse walking all the way down the hall for gloves, that's motion waste. A patient just sitting in the ER, waiting waste. Stockpiled medications slowly expiring on a backroom shelf, inventory waste. Lean is all about the pursuit of a continuous, totally waste-free flow. Now, our third concept is Kaizen. And Kaizen isn't really a strict by-the-books methodology like Six Sigma. It's honestly more of a cultural disposition. It simply means change toward the better, done by everyone, every single day, forever. It actively requires flattening the power dynamic. It's about giving everyone, no matter what their title is, the authority to pull the Anden cord to stop a defective process right in its tracks. Imagine a hospital where a cleaner is actually celebrated for pointing out a linen storage issue that was causing patient falls, and the issue gets fixed immediately. That right there is true Kaizen. And the mathematical reality of this kind of culture is just staggering. In a New Jersey hospital study by Graben and Swartz, over 5,000 small ideas submitted by frontline staff resulted in massive compounding gains. Why? Well, because if you improve a process by just 1% per week, which is a barely noticeable change on its own, the law of compounding kicks in and yields a massive 67% improvement over a single year.
All that unglamorous daily work compounds catastrophically in your favor.
All right, let's move on to Section 2, the African reframe. This is all about taking these tools and translating them to fit resource constraints.
Now, you might be wondering, aren't these just luxury tools for wealthy high-income hospitals? But here is a really provocative thesis. Toyota actually invented lean because of post-war scarcity, not abundance. They literally could not afford to waste anything. And that makes these methodologies perfectly suited, deeply native even, to resource-constrained health systems where every single wasted vial is a cost you simply cannot recover. And they are actively driving life-saving improvements right now. Just look at this map of success. Ethiopia used Kaizen to improve wait times and facility cleanliness. Kenya used Lean to slash outpatient wait times by up to 50%. Ghana used Lean Six Sigma to reduce lab turnarounds. Rwanda embedded quality improvement right into its very structure, driving major gains in maternal and HIV outcomes. These aren't just corporate buzzwords, they are vital, everyday tools working from Addis Ababa all the way to Kigali.
But we do have to translate the concepts, right? We can't just transplant them blindly. High-income hospital waste looks like a nurse walking too far, or capital unnecessarily tied up in supply closets. But African health system waste has a totally different, much more severe texture to it. It's a patient walking 4 hours to a clinic only to find the nurse is absent. It's an ambulance with absolutely no fuel. Addressing these catastrophic systemic wastes requires applying lean thinking across the entire district health continuum, not just inside the four walls of one hospital.
Furthermore, while these frameworks definitely rely on small data, which can absolutely be tracked on paper or digital health platforms like DHIS2, the cultural fit is surprisingly natural. Kaizen's fundamental requirement to flatten the hierarchy and actually listen to the front line resonates beautifully with indigenous African traditions of communal problem-solving. Whether it's the Baraza in East Africa, the Gada, or the Kokla, the underlying premise is exactly the same. Community wisdom is distributed, and it must be collectively surfaced. Which brings us to Section 3, the limits of pure efficiency, because sometimes optimization actually becomes a liability. We have to be intellectually honest about these frameworks. Prioritizing strict, highly measurable metrics like door-to-needle time can sometimes cost us the unmeasurable essence of human empathy, like taking the time to comfort a frightened patient at 3 a.m. We also have to contrast the relentless pursuit of pure efficiency with the need for systemic resilience. If you view a hospital strictly through a lean lens, an empty bed or a bunch of redundant inventory just looks like waste. But in healthcare, what looks like inefficiency on a spreadsheet is often vital slack. That redundant inventory is an absolutely essential buffer for climate shocks, sudden population displacements, or a sudden cholera outbreak. And the COVID-19 pandemic offered a very humbling lesson on this exact point. Hospitals that had stripped their supply chains completely down to the bone just to achieve Lean's highly optimized, just-in-time model, well, they found that their systems failed catastrophically in an unpredictable global emergency. It turns out, just-in-time can become just too late very quickly. The Toyota system was built for a highly stable manufacturing environment, but global healthcare, it is rarely entirely stable. So, what do we do with all this? Let's get into Section 4. The Monday Morning Action Plan, practical steps for your health system. Whether you are managing a high-tech clinic in Berlin or a busy district hospital in Bahir Dar, here are 4 immediate steps you can take next week without waiting for some massive budget approval or an expensive consulting firm. 1. Take a 30-minute Gemba walk. Just go stand where the work actually happens and observe the interruptions and the waiting. 2. Apply a mini DMAC to just one really frustrating process. Measure it, test a small change, and just see what happens. 3. Ask a junior staffer, a cleaner, or maybe the security guard for an idea, and then actually implement it. And 4. Read the incredibly rich intellectual literature from African health initiatives. Don't just rely on imported slide decks. I'm going to leave you with this final provocative thought. Think of the philosopher Plato's cave, or the reflections of Zer Jacob. The defects, the delays, and the harms we see every single day are really simply the shadows our current systems are casting. Turning around to look directly at those shadows, to rigorously and humbly fix the things casting them, that isn't a luxury. It is the ultimate act of taking healthcare and the real people who rely on it seriously. The inquiry never ends, does it? Thanks for watching this explainer.